It's a pleasure to be here today, and thank you, Kelly, for inviting me here to speak to this great audience about value-based payments and contracting, especially for community-based organizations. I think the move to VBP, as we're all sort of shifting our focus from moving from the volume of services that we provide to the value of it, there's a great potential, especially for community-based organization, and opportunity for them. So we'll talk about those opportunities that is in value-based payment for community-based organizations. We'll also kind of go over some of the resources that we have and support that we have at the Bureau of Social Determinants of Health at DOH. That bureau is also a new bureau that has been created. We're in March, so we're about 3 months old now since our inception, or since our announcement. So we'll talk about some of our goals pertaining to that. So how many people attended any of the boot camps that we had? Okay, good. So a great chunk of people. So I think a few of the slides here will kind of serve as a refresher for some of you, but we also included some new things, so I think it will be very helpful if you're listening to this for the first time or listening to it for the third time or so. Here's the slide that we put together just to kind of summarize what social determinants are, and I know that all of you in this room are providing services that address social determinants of health. So I don't need to kind of like go over this slide because I'm already speaking to the boots on the ground, people that are doing this type of work every single day. And then we also know that the impact of social determinants of health is very great for our members, and also addressing those can have very high drastic outcomes for those members and also for our healthcare system. It's also very less costly compared to traditional medical intervention, and so that's why we're kind of like focusing on that, because of one, it's less cost, and also it's high impact for members if the intervention is designed appropriately. We'll talk also about, and then the fourth point is that with the move to value-based payment, providers are really incentivized to really address some of the core issues that their members are facing, which usually has to do with the social determinants of health. So before we move into the meat and potatoes of this presentation, I kind of want to go over this slide to just have you thinking about what we have on here as a CBO who's thinking about going into a value-based payment contract, what you need to know, right? All right, this all sounds great. It sounds like a great opportunity, but what do I do? Where do I go from here? What should I be thinking about? And so the first thing here is for you to really understand the needs of your community. Most CBOs have been in existence for some time. They know exactly what the needs of their communities are, and so then you want to use that knowledge and to bring that over to the managed care organization and to show them that this is what you do and this is what is needed in the community. The second point is to also know the key partners in the community, right? So which PPS are you, whose catchment area are you in terms of the provider systems, which managed care organizations operate in the region that you're providing services, and what larger provider systems are also operating in that same area. Are there other CBOs that are providing a similar service that you are doing, or are there other CBOs that you can partner with to approach a managed care organization with a proposal? And the third thing is to understand the value-based payment levels. As Vanessa went over this morning, there are some bundles of care that are available for managed care organizations and VBP contractors to choose from and to contracting. So you want to be knowledgeable of that. If a managed care organization or an IPA has a contract for maternity care and you provide prenatal services, it will be good for you to know so you can go and market yourself to that particular provider, right? Say, this is what I do. I know you need me, because in each of those contracts or in each of those bundles, there are metrics that needs to be met. There are outcome measures that need to be met. So you as a CBO will be able to help them meet those goals. So you need to know those arrangements. And also, again, going back to knowing those levels, determine the interventions that you are going to implement and the intervention that will help this particular managed care organization and IPA or ACO meet their needs. So you're tailoring your intervention to meet their needs. And then the last thing is to develop your value proposition. So you have data. I know there's been a couple of questions on where do we get data from, but as a CBO, you collect a fair good amount of data from the patients and the population and the members that you serve. You can use some of those data to show your value and to present that to a managed care organization to get the conversation started, at least, if not to get a contract in place, to at least start talking. So the next few slides will be kind of like a review of what the roadmap says about social determinants of health and CBOs. This first one is just what the standard. So as we go through this, you see something that says a standard, and others will say a guideline. So a standard pretty much is what the requirement is, right? So you have to do this. So this is part of it. There are no two ways about that. And then a guideline will be a suggestion. So there's more flexibility with those guideline items in the roadmap. So this very first standard is that managed organizations that enter into a level 2 and 3 arrangement will have at least one social determinant of health intervention in that arrangement. They have to identify at least one intervention in their arrangement if that contract is a level 2 or 3. All right. And the selection of that intervention is solely up to the managed care organization and the IPA and the ACO, and also the community-based organization that's involved. So they could decide which intervention that they want to address. But we've also provided on our DOH website what we're calling the Social Determinants of Health Intervention Menu, which sort of breaks that into like 5 different categories or 5 different domains. And under each domain, there is sort of like broad interventions or broad issues that you can sort of deep dive into and select an intervention from. That menu is on our website, and it's a spreadsheet with live hyperlinks in there, so you can also use that for data and for sources on social determinants of health. So that is there to be looked at. All right. So then the next slide is kind of like a slide from our MRT supportive housing. That's one of the programs that Project Host is a grant program that funds Project Host. And we're actually in the second year of a 3-year evaluation. And we put this here just to show some of the outcomes of the evaluation and the programs that we're looking at right now. And in the middle there, you can see that by providing supportive housing to high-need, high-cost Medicaid members, there were 40% reduction in inpatient days. And there were about close to 12,000 members that were in this particular study that we looked at for this report. So you have the 40%, you have 26% reduction in emergency department visit, 44% reduction in patients with inpatient rehab admission. So you can go down the list, and I think we all will agree that housing someone really, providing housing to someone who is homeless, high need, high cost is a great intervention that can bring some pretty impressive outcomes, as you can see on the slide. And then the next example we have here is from God's Love We Deliver. There is a community-based organization down in New York City and provides medically tailored meals. So they've sort of have been able to, they initially started off providing just meals for individuals with HIV, but seeing the need for this kind of intervention, they sort of opened it up to anyone who is homebound with, regardless of your medical diagnosis or need, provide, if you needed the intervention, they were there to serve you. So a point that sticks out really to me is the fact that you can feed someone for 6 months at the same cost of one night in the hospital, right? So 6 months, just one night. So it's a really great intervention, and with some very, very impressive outcomes.
Is that a grant-funded program?
No, it's not a grant, not from us, but I think they do a lot of foundations, a lot of fundraising. So, and with the move to value-based payments, I know that they're now working with a lot of managed care organizations, MLTC, the PACE programs too. So more about the community-based organization requirement and value-based payments. Again, this is the standard, so it's required that managed care organizations that are in a level 2 and 3 arrangement have at least one tier 1 CBO in their contract. So now the first requirement is that they need to have an SDH, and now the second is that they need to contract with one tier 1 community-based organization. We know that that is the requirement, so it's the minimum. However, we've always encouraged managed organizations and VBP contractors to include more than one CBOs and also CBOs across the tiers. So contract with tier 2 and 3 CBOs also to address the social determinants of health interventions that they've identified. All right. And here is a quick sort of breakdown of the tier 1, 2, and 3 CBOs. I know someone asked a question about what is a tier 1 CBO earlier this morning. So you can see a tier 1 CBO is a not-profit, not Medicaid billing, community-based social and human service organization. It's important to note that if you have a portion of your organization that bills under Medicaid, as long as they have the same sort of tax ID number or they're under the same umbrella, they're not considered a tier 1. So that definition is pretty strict, right? And then the tier 2 is a nonprofit, Medicaid billing, non-clinical service providers, such as your transportation provider. And then the tier 3 is nonprofit, Medicaid billing, clinical and clinical support service providers. So entities that are licensed by the state to provide services are considered tier 3 CBO. And I know that there's something down there that says we have a CBO list. I'll talk a little bit more about that in the next, I think, 2 slides or so. So here's a slide that we put together to sort of talk about the role that we see tier 2 and 3 CBOs playing in VBP contracting. Again, although the roadmap says that at least one tier 1 CBO has to be contracted, it's the least that managed care organizations can do. So we are also sort of pushing them in the direction of including more than one CBOs and including CBOs on tier 2 and 3. So we think that here's where a CBO on the tier 2 and 3 CBOs can help, is that the more the merrier for CBOs. The more a managed organization has CBOs in their contract, the more they might be able to meet quickly some of those outcome measures that they've set for themselves, and those measures that are in their bundle of care that they've contracted into in value-based payments. So we say make a friend, right? Tier 2 and 3 CBOs may partner with the Tier 1 CBO to support the implementation of an SDH. If a Tier 1 is sort of getting ready to get staff together because they're part of the arrangement to meet the Tier 1, to meet the level 2 and 3 VBP requirement, while they're doing that, while they're getting ready to provide those services, Tier 2 and 3 can in the meantime be addressing those SDH intervention and those SDH challenges that they've already identified for that particular managed care organization or for that particular bundle of care that they're working under. So by addressing, VBP contractors are incentivized to include multiple CBOs, and we've talked about that. So by addressing SDH, CBOs can have a larger impact on the overall healthcare and health of the Medicaid member, which may result in more shared savings for the value-based contractor. So align with the VBP arrangements. Again, if you know the managed organizations that are in your catchment area, if one of them has a contract for maternity care, you want to be there if the services you provide is for prenatal care. It makes sense to want to work with that particular managed care organization under that particular VBP arrangement, because that's the services that you provide. So you want to be mindful of that. If you provide service for the HARP population, you might want to align yourself with a managed care organization that is in a HARP VBP arrangement. To cover a larger geographical area, so Tier 2 and 3 CBOs, for the most part, are very large, and so they have a larger catchment area. So if you're a larger managed care organization and you're trying to provide members that are spread out in one geographical region, it might be a good idea to contract with the Tier 2 or 3 CBO just because of their reach, just because they're able to reach the members that are sort of not so close geographically in the same area. So here's the CBO, sort of a quick preliminary results from our CBO survey. Earlier this year, we released a CBO survey with the purpose of, one, gauging CBO engagements or gauging what CBOs are doing in value-based payments, whether or not they're having conversations with managed care organizations, and if they've moved the needle towards getting into a VBP contract. And also we wanted to use the results from that survey to create a CBO directory. And that directory is actually on our website. It's updated bi-weekly. If you're a CBO here and you have not completed that survey, I can send the link over to Kelly, and then you can sort of send it out. It takes about maybe 7 minutes to complete. Yes?
So at the risk of asking a really ignorant question, because I've been doing district from the beginning, what's the reason for the distinction between Tier 1, Tier 2, and Tier 3 CBOs? Like, you must have a Tier 1, or like, why? As opposed to just the CBO. I've really never been able to get my head around that.
So I think that actually came from the VBP work group, and they were putting together the roadmap also, and I think the idea was to also help some of the very small CBOs, right, that were not billing Medicaid. They were providing really good services, but also were struggling to kind of like find funding. So to bring them also into the healthcare, because we see a great need for CBOs to be a part of the healthcare system as opposed to being a siloed entity. So I think that's why Tier 1 CBOs are sort of included in that. And I want to say that we recognize that, yes, we have to include all tier CBOs in these arrangements. So we've actually proposed a language change to CMS to say that tier 2 and 3 CBOs are also should also be included in VBP contracts. So once that's approved, it will be updated in the current roadmap that's on our website.
Thanks.
Okay. So as you can see, as of last Friday, we've had about 441 respondents to our survey. 33% of those respondents identified themselves as a tier 1 CBO, and you have tier 2 and tier 3 at 45 being the greatest of our CBO tier. And then 43% of those who've answered the survey have said that they have met with a managed organization and a VBP contractor to at least start a conversation about being a part of those, being a part of a value-based payment arrangement. Again, the tier designation actually is self-reported, so the CBOs, as they're filling out the survey, are checking off what tiers that they're on, and that is, we left it as that. We didn't really change that. We didn't really edit anything from the survey, because we wanted managed organizations to be able to filter those, the directory, to either find a CBO on any different tier or a CBO that provides a particular service that they're looking for. So those that the document is something that you can search and find what you're looking for. Even if it's geographical region, you could put a county in, and it will tell you CBOs in that particular county and what services they provide. All right. So here are some contracting strategies too. Again, I think someone asked this question earlier too, like how do we see a CBO in a value-based payment contract? So the next few slides will go over those contracting scenarios. You see here in a value-based payment arrangement, the managed organization with a contract with a value-based with the VBP contractor, but it's then contracting directly to a CBO to provide a service for their members. So what's on the far left is kind of like an example or an illustration of what it will look like in real life. So you have Greenleaf Managed Care in a total cost for general population, a level 2 arrangement with the hospital, and also Greenleaf is contracting directly with Hazelcrest, which is a housing CBO. Yes.
Is there some requirement that MCOs contract with CBOs that's apart from the value-based contract, or I think I had seen something about a requirement related to managed long-term care organizations?
So is the question is whether they're required to contract with the CBO in value-based payment?
Even apart from value-based payment, is there an obligation for MCOs and MLTCPs to contract with CBOs?
So I think, I mean, for this is all about value-based payment. So if you're going in as a level 2 VBP arrangement, then you do need to meet these two requirements: a contract with the CBO and also have a social determinants of health. But if you're not planning on moving to VBP, then this will not be a requirement that pertains to you. But I think in general, though, you want to kind of like take a look at your business model, because if it's, I think there's a lot to be said about working with a community-based organization to kind of like help your bottom line, right? Your patient outcomes and things like that. So even if you're not moving into VBP, it might be something to think about, including CBOs in the work that you do. Yeah, no, I think this is all for value-based payment arrangements. Oops. Right. And then the second contracting strategy is a single CBO arrangement directly with the managed care organization. But here you see the CBO supporting 3 different value-based payment contracts. So just that one CBO supporting all 3 VBP arrangements. So here's where we talk about the reach of that CBO, right? Are they broad enough to be able to support 3 different VBP arrangements. You could also see CBOs that here in this category, maybe joining together with other CBOs to be in an arrangement like this one. And then the third is a subcontract arrangement where the CBO is not contracting directly with the managed care organization, but rather with the value-based payment contractor, which would be either the hospital, the IPA, or the ACO, but also just to serve the patients or the members that are involved in this particular arrangement. All right. And we talked about this a fair bit in our boot camps. It's like the contracting strategies or the contracting options for community-based organization. And most CBOs would ask, do we have to take on risk to be a part of value-based payment, right? We are a small CBO, we don't have that much money, we don't have a lot operating dollars, do we have to take on risk? And the answer to that is no, a CBO does not have to take on risk to be a part of value-based payment arrangement. They can want either be in a VBP contract, but remain a payment for services rendered provider. So those contracts that fall under the first category have no risk components to them. The second one is the upside only. So there's no downside risk, and if savings are achieved, the CBO receives a portion of the savings, and if losses are incurred, they don't have to take on any part of that loss.
Can you just, as you get into this topic of risk, can you just re-explain that, or explain it for us so that I'm not as familiar with that? How is that gain or risk determined? Is that at the top level, is DOH kind of looking at each MCL and saying this is how much money we're paying them for the year, so here's the capital that we're going to allow them to play with in terms of a potential savings at some point? Can you explain how that at least globally works? Because I'm having a hard time getting from there. It's a big payment organization that kind of has to do all the raising and bill paying for the state down to the provider level, and how people are going to share risk, either to see some gains or losses. Who's going to determine whether you've met or lost?
Right. So the contract is actually between either the CBO and either the IPA or the managed care organizations. Or the managed care organization. So how you determine what's a loss, like it's an agreement. So you're having a discussion, right? This is how much we're going to invest in this. This is how much seed money we're going to put in this, and we expect this amount of money generated. And if you don't, then that's a loss. If you come up with more, then that's a gain. Those are all contractual agreement that the CBO will have with the managed care organization or the IPA. So if you're a CBO, you know your value, you know what you're capable of doing, you know that. So that's where you're bringing all those experiences to the table and discussing how much you're willing to take on.
So the MCL then's kind of looking at like how much money are we getting paid by the state per beneficiary, and determining how much out of the budget for that person they're going to be able to contract out for services, and then kind of just determining somewhat arbitrarily based on whatever information they have, what would be, kind of meeting the goal and people would be rewarded. Am I kind of following along here, or am I?
That's kind of like what the idea is, and what we're trying to do is to be very transparent in terms of those reimbursements for those managed care organization. And I think there's when we did the boot camp, there was a finance class that was kind of dedicated to those particular compensation. But the idea is that for the CBO and the managed care contracts, those two will be speaking and coming to an agreement in terms of how losses will be kind of shared, or who's taking on, how much percentage you're taking, and how much percentage you're taking of the loss, and how much percentage you're taking of the gains. So if that sort of helps. Yes.
Yes. In the title of this workshop, it said that we were going to be able to identify resources for CBOs. So, for example, if these contracts are requiring data and analytics and all of that. For small CBOs that don't have that in their, as part of their infrastructure, number one. Number two, just the wherewithal to enter into a contract to begin with, even though we might be providing the service. Where do we begin? Because I know I could do the service, but I can't even begin to start with this. So to me, I would like to know what resources DOH or somebody should be offering us to be able to get into the game.
Absolutely, and that's true, right? So when we did our survey, there was a part for people to kind of like ask questions or how we can help to move small CBOs into value-based payment or to get CBOs ready for this. And we'll talk a bit about some of the resources that are available. I think it's coming up in the slides. We'll talk about that. We'll talk about the data share because this is not sort of the first time that we've heard it. We know it's a challenge for CBOs, right? For most part, some of the CBOs are still using spreadsheet and Excel or paper to collect data. So yeah, we'll talk about some of the data aspects of it. All right. And then the third one is just the upside and downside risk. We know that not a lot of CBOs will be able to take on or will be able to enter into contracts like that. But I think if you're a CBO providing a service that is tailored to high cost, high need Medicaid members, I don't see a reason why that would be a scary thing for you to enter into such an arrangement, right? And then the last point that I want to make on this is that although CBOs don't have to take on risk, they will be held to performance measures, right? So if you're contracted to provide X amount of service to X amount of people, the managed care organization will be holding you to those numbers and to those performance measures. All right. So here are some of the resources that we have, and to your point, right? So we have, through district, we have the community-based organization planning grants. So these planning grants is supposed to provide administrative help for CBOs that are looking or to get them ready into getting into value-based payment arrangements. And so you could see for New York City, we have Arthur Ashe, and for Long Island and Hudson region, you have the Health and Welfare Council of Long Island. The rest of states, RFA just got released for the rest of state. This was about last week, so if there's a CBO here, a CBO consortium that is interested, this is, I think, an opportunity to sort of apply for some of these grants, yeah.
Is that only eligible for tier 1 CBOs?
No, no. I think it's open to a larger pool of, I think there's a requirement though. I think there's a limit of the budget has to be $5 million. I'm not sure, but I can send that also to Kelly to sort of send around. Yes.
First a comment to that and then a question. So to that question of the infrastructure costs, I would have thought that the ACO or the MCO or the PPS, so they're contracting with a community-based organization that's going to offer the infrastructure, analytics, and IT, whatever's needed to track the progress that they need to track. They may or may not, but I think in some cases they are. My question was, does DOH have on its website either model contracts or model clauses, or are there required clauses for the contracts with CBOs the way there are for the IPA MCO contracts?
So I think we've been hearing that a lot of the model contracts that we have now are kind of like the clauses in their Medicaid for like Medicaid billing. So some of the CBOs don't feel comfortable using those. So we're thinking about maybe coming up with a template sort of agreement for CBO contracting that will not have all those clauses and jargons in there that sort of scares CBOs away. So we're thinking about that. But in the meantime, what we've said is that an agreement between the managed care organization and the CBO, sort of laying out what the responsibilities are, what the measurements will be, what the funding is going to be, will be acceptable to DOH at this time. So it doesn't have to be a model contract, but it could be like an agreement between the parties to provide services. So that's fun.
Does DOH review those contracts the way it reviews?
Yeah, we do. Yes, we do. We review the CBO contracts. Yes.
Okay, so I gotta draft one next week. I don't know what.
Yeah, it would actually be coming to myself and some other folks on our team. So yes, we do look at those contracts.
Okay,
So.
well, I'm gonna start with a blank piece of paper and see.
Okay. All right. And then the second thing is also like the PPS, the district PPS, which is what you were saying, that some of the PPS should be providing some of those data needs. And yes, the PPS will sort of maybe have data that you can use to put together your value proposition. They also have some funds that are available to community-based organizations. You have the Innovation Fund, that is a funding opportunity to support the CBOs, right, to get ready and move into value-based payment. You have the Transformation Fund, which I think these two are kind of like an RFA sort of thing that you have to kind of apply for, right? So the Transformation Fund seeks to kind of fund projects that are designed to address some of those gaps in care. And then you have the Workforce Fund as well. And also then we have the third stimulus adjustment. In the roadmap, MCOs are supposed to, they're tasked with providing seed money for community-based organizations to implement their SDH. So knowing that, you can, when you're negotiating your contract, you can bring that up. We also want to say that managed care organizations did receive a stimulus adjustment dollars. Those dollars were not earmarked for anything in particular, so no particular projects or reinvestment. So that could be an avenue where a CBO can negotiate some of those dollars for their SDH intervention as startup funds before they get into an actual contract with the managed care organization. We will provide the sustaining funds for those particular interventions and projects. Right. So I think this is, so as I said before, I think in December 2017 was when OHIP announced the creation of our new bureau, the Bureau of Social Determinants of Health. And we sort of have put together a couple of goals for this year. The first, of course, being that we're the ones responsible for reviewing all those VBP contracts that come in that has the CBO and the SDH components. So that will be kind of like one of our main focus, to review the VBP level 2 and 3 contracts and amendments, and then to track those interventions that the CBOs and the managed care organizations are doing. So that is sort of our hat. We want to make sure that the requirement to have at least one SDH is met by the managed care, and then to have at least one Tier 1 CBO in their arrangements. When those contracts come in, the contract team takes up what they need to take a look at, right? So they have the model Medicaid contract to look at. We get the social determinants of health intervention template that the MCOs send over to us, in addition to the CBO arrangement agreements that they have. So we're looking at those to make sure that yes, they're actually going to be providing funding for the CBO to do the work. These are the quality measures that they're going to be looking at, and then following through, we'll be actually evaluating those programs in later years. The second goal is to also bring begin CBO SDH regional meetings. I think at the end of our boot camps last year, we felt like, yes, this is a great thing, value-based payment, but we also need to get CBOs ready for this world, right? If we're changing the model of care, we need to get community-based organizations ready to be able to play ball with managed care, with the MCOs. So we're going to be having regional meetings across the state. I'm not sure if it's going to be, the regions will be broken down similarly to the value-based payment regions. I don't know that yet, but I know we're going to be doing regional meetings, a collaboration, working with the PPSs in the region and the FIBs also in the region. So we'll try to kind of consolidate the meetings because we don't want to be pulling CBOs in many different directions. So if there's a regional consortium meeting in a particular region, we want to maybe tag along there and have a learning collaborative. The format of that, we're still sort of talking through, and some of the questions that you guys have asked here will also form the basis of some of the information that we provide at those regional meetings.
The Conference of Local Mental Hygiene Directors convened about 2 years ago these regional planning consortiums, RPCs, and CBOs are part of those. So that, you mentioned if there's already a structure, and we meet, I think, quarterly,
Okay.
that would be, so again, the Conference of Local Mental Hygiene Directors, they're the coordinating body. They have staff, and there's also regional staff throughout the state for these RPCs. And that might be a good way to bring the CBO.
That's good. Maybe we could talk a little bit later.
Sure.
I'll get more information. Thank you. And then the third is improve the SDH measures in population health and payment reform. And Nessa talked earlier this morning about those quality measures that are embedded in every single VBP arrangement. We noticed that, like for SDH, there really isn't a clear quality measure out there. I think the HARP bundle has maybe 2 measures that you could argue are SDH, that are measuring SDH, but there is really nothing standardized for all the different types of SDH that are going to be out there, right? So if you're providing food, if you're responding to a lack of housing or food insecurity or medically tailored meals, some of the HARP SDH measures will really not pertain to you. So we want to kind of like talk about that, and we've been having conversations with our quality measure team at DOH to sort of see what are maybe 1, 2, or 3 quality measures that we can put in place for SDH in general. Another thing we're doing is also kind of like thinking about risk adjustment for SDH, right? Risk adjusted for social determinants of health for the managed care organizations. Our neighbors in Massachusetts have done something similar to that, where they take census data and they're looking at the level of poverty in a neighborhood, high school dropout rates, employment rate, whether you have a car, and those kinds of things. Sort of like hotspotting individuals and using those data to risk adjust for social determinants of health. So we're embarking on a journey similar to that. We've had conversations with Massachusetts, and Rhode Island is also doing a small pilot similar to that. Kind of want to harvest some of their ideas. We know that we're going to need data for that, right? So which SDH do we want to look at? What is the data saying about it, and how do we really include that in, how do we risk adjust for that, and what is that going to look like? So that's kind of like a big project, but I think it's a really good way to go, because ultimately what we want to do is have our doctor write a prescription for housing, or write a prescription for healthy food, and for the managed organization to be able to cover that. So we're still kind of like working on that part. And then the fourth is to create a new housing referral process. Before we became the Bureau of Social Determinants of Health, we were the Bureau of Supportive Housing. It was kind of like what it was Governor Cuomo's Supportive Housing Initiative back about in 2012. And so to date, he's invested about $641 million in supportive housing. So that initiative sat in the Bureau of Housing, and that was the program that we run up until last year when we became the Bureau of Social Determinants of Health. So we still carry that hat on, and what we want to do now is to sort of streamline the referral process for those capital projects that we fund. So that funding actually supported rental subsidies, capital projects, services for individuals that are high-cost, high-need Medicaid members. So we want to be able to prioritize the members and the patients that really will benefit from that sort of housing. So the referrals will come from either the PPSs, directly from the managed care organizations themselves, or the CBOs that they're working with to house them in those MRT supportive housing, as opposed to what it is now. So that's something that we're also going to be working on. And then the third is where we want to expand our programs to families as well. I think all of our MRT projects, there were pilot programs and they were for single adults, but we're moving to including families into that as well. Another initiative, and I think it's on the next slide, is also our first 1,000 days. That was initially outside of the Bureau of Social Determinants, but it's going to be something that we'll be working on next. So that first 1,000 days initiative will be a project that my bureau will be overseeing. And then, so this is a prevention and gender goals. We've been working with some of our sister agencies across the state. So Office of Public Health, the Chronic Disease Management Team, to kind of talk about some of the trailing prevention agendas. If you've ever been on our website, there's a tab for prevention agenda. If you click on it, you can see on the dashboard, you can see all the trailing conditions and how we're doing in them. When you click on those further, you can see by county and by region how that particular health condition is affecting the members in those communities. So the roadmap kind of volunteered us to do this, but I think it's a great cause, and we'll be working on a pilot to address asthma, which is like one of the trailing prevention agenda needs in our state. So we're in the development stage of a pilot program for asthma, and we're working in conjunction with our friends from Office of Public Health in designing this pilot, and NYSERDA as well, working on that. And so these will be the three prevention agenda items that we work on over the next couple of months. But the asthma pilot, we're closer to having the asthma pilot than the diabetes in the first 1,000 days. So as a closing thought, just put this slide together as kind of like some of the takeaways. So I think the first thing to sort of remember is that managed care organizations, they need you. They need to contract with you in order for their contracts to be a real level 2 or a level 3. So if they're not coming over to you, you can go to them. I think one thing we've been thinking about, we have their CBO survey, and we've published the directory online, and I just want to say that that directory is not, we know that it doesn't include every CBO in the state, but it's sort of an idea for managed organizations to sort of use if they didn't know where to go, but it's kind of the start of reaching out to CBOs. So we're thinking of maybe doing something similar, maybe surveying managed care organization and IPAs and ACOs, and also putting their list or their directory online as well to make that more like a synergy between CBOs and managed care organizations. So we're thinking through that. And let's see. So CBOs may provide a number of services and function within the provider sister network. Again, the work that you guys do is sort of going to drive managed care organizations, whether or not they meet their targets or whether or not they meet their outcomes. It depends on the work that you do. So they need to come to you in a nutshell, and you guys need each other. Tier 2 and 3 CBOs play a vital role in strengthening the provider network. MCOs and lead VBP contractors are encouraged to engage over CBO types. We'll continue to say that, and once we get that CMS to approve those amendments to the roadmap pertaining to tier 2 and 3 CBOs. We'll update the roadmap, and it will also be available on our website. So yeah, this is it for now. And if you have any questions, that's our BML. It comes directly to our team. We've had, since the announcement of our bureau, we've taken emails and calls from a number of providers. We've met with a lot of people. If you have any question, if you just don't know or want additional information, even if you're in a contract stages with the managed organization and you just want us to look over your intervention template just to give you feedback, we're happy to do that. So please reach out.